Dear friends, we have seen in the first chapter that the idiopathic epiretinal membrane differs from pure edema only in the presence of hyaloid fibers attached to the ileum and mixed with the glial proliferation reactive to ischemia. Except for its influence on metamorphopsia disappearance, the removal of these two adjoining structures cannot have any beneficial effect in itself. We have also seen in the previous chapter that in an idiopathic epiretinal membrane, the ileum peeling acts through the creation of a retinal trauma, the tearing of the Müller cell hand feet, responsible for an almost tumor-like expression of EGFR over the entire retinal thickness, and a cascade of reactions specific to mechanical trauma associating resorption of edema via Müller cell gliosis, prolonged neuronal survival, and cellular regeneration mechanisms. There was then nothing to prevent this peeling from having the same beneficial effect in cases of pure edema as in membranes. I have been practicing the ileum peeling in Irvinga syndromes since the beginning of the 90s, so I extended my indications to diabetic edema and post-vein occlusion edema at the end of the 90s. I presented my first 9 cases of post-occlusion edema surgery in 2001 during the Retina Biarritz Congress and, of course, afterwards. The results were immediately exciting, as demonstrated by the growing number of patients with post-vein occlusion edema sent by my referring ophthalmologists. So I presented a statistic at the EVRS Prague Congress in 2008, interesting in more than one way. The only selection criteria was pre- and post-op visual acuity, and all the information was provided by the referring ophthalmologists, which explains, firstly, that out of the 352 patients operated, only 236 were accounted for, but also that there were no optimization of the result in this study, as can be seen in some prospective studies where the correction by glasses is changed and the cataract operated. It reflects the true vision for your patients that you will obtain if you do this kind of surgery. Note that there was much more cases of central vein occlusion than branch vein exclusion, explaining that 75% of eyes had 2200 or less before the operation. The average visual improvement was more than 4 logMAR lines. This is to say about 2.5 times the amount before the operation. I had the idea to inject Kenacort before the surgery, thinking I would pump the edema before the Müllerian gliosis blocked the retinal thickness. Surprisingly, eyes with preoperative Kenacort showed poorer visual recovery. Overall, 70% of patients had visual improvement and only 6% had a decrease. There were all patients with central vein occlusion and all had non-infusion extended areas. As with any macular pathology, improvement varied linearly with preoperative acuities. Improvements were quite similar to those obtained by ILM peeling in idiopathic membrane, macular hole, Irvinga syndromes, and diabetic edemas, confirming, if needed, that the repairing action of the mechanical trauma caused by the ILM peeling does not depend on the cause of the edema. Interestingly, the visual improvement increased over the time to obtain more than 5 logMAR lines after 1 year, and in long-term results, with an average of 5-year follow-up presented in Dresden in 2012, more than 6 lines after 2 years, of course without any additional treatment. Finally, the reduction in macular thickness was 200 microns on average. In the long-term result, it could be noted that after a 3-year follow-up, macula tended to increase in thickness even if visual improvement continued to increase. This allowed us to say that we need to take a step back on OCT postoperative measurements. So as you can see, exciting results that I started to share with a lot of operators. Some French, Jean-Paul Amar, for example, published in 2012 at the Dresden meeting a study of 131 cases out of 193 operated with a minimum follow-up of 6 months and found results perfectly identical. I did not have enough numbers to report on diabetic edema, but others like Ferencun and Andreas Schuler presented on several hundred cases each. And since we are talking about diabetes, you now understand, after having seen the 2 previous chapters, that this distinction between diffuse diabetic edema and tractional edema, whether due to the action of an epithelial membrane or hyaloid traction, can only be distinguished, as I said in chapter 1, by the presence or absence of a mixture of astrocytic lysis and posterior hyaloid fibers in contact with the ILM. I am therefore opposed to this distinction in edema. The treatment is the same and the results depend only on the damage done before the surgery. Anyway, the fact that the visual improvement is the same, whatever the etiology of the edema, and does not depend on the existence or not on epiretinal structures, confirm our explanation on the action of the ILM peeling. In 2005, I introduced in France with Guy Lelgouache and Claude Boucher the treatment of AMD by injection of Avastin. I stopped at that time without any difficulty the surgical indication in AMD, which presented in my hands better result than PDT, but very much worse than with anti-VEGF. However, when anti-VEGF has been introduced for the treatment of edema, I found that the results were much worse than those obtained by surgery. The laboratories having refused to do comparative studies anti-VEGF versus surgery, I decided to a study within the European Society of Retina, EVRS. The organization of this study was simplified by the EVRS RD study that I had organized the year before, and which I will talk about in a few chapters when we discuss the retinal detachment. I had, for this work, met with very high-level data scientists who explained to me the following. You will never be able to make a prospective randomized study large enough to obtain statistically significant results for financial reasons. It should be raised for that several millions euro that you will never get either from the government or from sponsors. It will be out of question to find a rate such as numerous line of visual improvement. If you want this, only a prospective randomized study is possible. Why? Because in a retrospective study, doctors can exert a selection of the cases they send, which renders the result found unreliable. However, you can compare the result obtained by two different techniques with a statistical strength almost equal to a randomized prospective study, provided that never to present growth rates but only comparisons, to have enough patients for each technique, and above all, enough doctors for each technique so that statistically the percentage of those who make selection is the same in each of the two groups. And finally, for a prospective study as for a retrospective study, the reliability of the study will depend on the absence of bias, and that must be understood. A randomized prospective study, if it is done on 4 hospitals in the same country, with 8 doctors using the same equipment, will not be reliable because it will accumulate too much statistical bias. To do it right, you have to check that there are enough different countries as the possibility of access to care in each country is variable, a mix of public and private institutions, a comparable experience of the physicians for each technique, a variety of equipment or machine used for each technique, etc., etc. If all these biases are eliminated, a retrospective comparative study may even be more credible than a randomized prospective study of the same size, but with significant statistical bias. The EVRS study, having met all these criteria and being the only global multicentric study comparing the efficacy of all treatments, laser, surgery, triamcinolone, Ozurdex, anti-VEGF, as well as their combination, I am proud to present the main results. 85 retina specialists from 29 countries sent us 2,603 cases of macular edema more than 300 microns thick, with a minimum follow-up of 6 months. And let's start with edema after vein occlusion. 738 cases with about the same number of central vein occlusion as of branch vein occlusion were submitted by 53 physicians and treated either by monotherapies or by combined treatments. The number of patients increasing their vision of 3 lines or more is higher after ILM peeling than after anti-VEGF. This result is statistically significant. Same thing for the increase of 6 lines or more. However, this classical way of presenting is not free of reproach because, as we have seen, the improvement depends on the vision before the treatment. This is why it is much more accurate to present things according to the initial visual acuity. We can then declare that the gold medal returned to ILM peeling with an average increase 2 to 3 times greater than after anti-VEGF, who get the silver medal. Now let's go to diabetic edema. 870 cases of edema greater than 300 microns treated by 60 doctors, either with monotherapy or association. Here again, the number of patients increasing their vision by 3 lines or more or 6 lines or more is higher after ILM peeling than after anti-VEGF. This result is statistically significant. And if we compare the visual increase according to the initial visual acuity, the goal comes back to ILM peeling with a visual increase 3 times higher than that obtained by the combination ILM peeling triamcinolone, who received the silver medal, the bronze medal going to anti-VEGF. Regarding the efficiency on retinal thickness, the surgery seems to drive out less the retina than the anti-VEGF. We calculated the correlation coefficient between macular thickness and visual acuity before and after treatment and found that the relationship between visual acuity and retinal thickness was significantly higher before treatment than afterward, which confirmed that one must take a step back on the predictive value of OCT after surgery. To try to understand this phenomenon, we analyzed the evolution of retinal thickness for each treatment using mustache boxes. Here, the distribution before treatment, and here after treatment. We see that the population treated by the ILM peeling has a smaller reduction in edema and has a smaller dispersion. But if we now consider the risk of atrophic evolution, we see that all groups, except for surgery, have at least 10% of their population with a thickness of less than 180 or 170 microns. This may explain that a larger decrease in thickness is not necessarily synonymous with better visual improvements. Let's see now the complications. The development of cataract is more common in the group of ILM and triamcinolone, and this is statistically significant. The occurrence of glaucoma is more frequent in the ozurdex or triamcinolone group, and this is statistically significant. Surprisingly, no significant difference was observed with regard to the occurrence of retinal detachment, choroidal detachment, intravenous hemorrhage, or macular hole. A comparison on endophthalmitis rate could not be made due to the small number of patients, but a simple multiplication proves that the risk after 10 or 15 injections is much more important than after a single surgery. In the end, the vitrectomy with ILM peeling is the best therapeutic approach for all these etiologies of macular edema without giving more complication than the other treatments. You can notice on this summary table that the association surgery triamcinolone, here in pink, gives infinitely less good result than surgery alone. This is reminiscent of the experience I had at the beginning of my venous occlusion surgery, where the association with Kenacort had decreased the improvements. Why? Remember my diagram on the cascade of reaction caused by the ILM trauma. under the effect of EGFR stimulation, Müller cells increase the production of pro-inflammatory factors, which themselves has a positive retro impact on the stimulation of Müller cells. Madinier reminds us that the inflammatory response to ischemia is beneficial because it stimulates microglia. McAllister proves that in burst vein occlusion, triamcinolone reduces GFAP in Müller cells and thus decreases the reaction against ischemia. All this proves the interest of respecting this inflammatory reaction, which is part of the body's response to ischemia. So you see, there is no doubt, whether for membrane or edema, the stimulation of EGFR induced by the mechanical trauma of the ileum peeling allows the best visual recovery rates. Why this surgery is not performed more regularly? What will be the indication and conditions for performing this surgery? This is what we will see in the next chapter.